Cool. Well, welcome everybody. We are so delighted that you're here. Again, my name is Nicole. I'm heading up community marketing over at Trusted Health. And if you're not familiar with Trusted, we are the place for the modern nurse. Not only do we place nurses in a variety of travel assignments, which you are probably familiar with, but we also have just a wealth of career resources, events to blog articles, virtual events like these. We have a podcast, just really the place for you to kind of advance your career. And so without further ado, I'll go through a welcome quick, and then I'll hand it over to our amazing host, Sondra Smith. So a couple of virtual event norms that we like to go through for every virtual event. And I will go through these because I know you're all great readers, but good vibes, good times. This is a time to have fun, be present, get a lot of really wonderful information to help you care for your patients. Number two, we do want to hear you, but only when you want to be heard. So if you're not talking, go ahead and just keep yourself on mute. We know that there's a lot going on, especially in the virtual setting, so just keep that mute button handy. And if you have questions, this is the third one, make sure you use the Zoom chat. Casey and I will both be taking all those questions and bucketing them for Sondra after each section of her presentation. There's a lot of information in this one, so most likely some of your questions might be answered as the information goes along. And then the last one, which is really important for us at Trusted, as well as for Sondra, if you have feedback, please share it. There is an email after every event that asks for feedback about virtual events, about this event specifically, and it is really helpful and important for us as we continue to build out our community program. So please share your feedback. And if we're ready, here we go. I'm going to introduce your illustrious host. This is Sondra Smith. She's amazing. You can see how to contact her at the bottom, both on Instagram as well as Twitter. And without further ado, I'm going to let Sondra take the reins. I'll stop sharing.
All right. Okay, so we will go ahead and get started. Like Nicole said, my name is Sondra Smith. I am a family nurse practitioner here in Indianapolis. I started at Chatham Care in the past month. I have been here throughout my master's program as a family nurse practitioner. About 5 years ago, I went to a conference about transgender health and really kind of realized there's a gap in knowledge, a gap in care. And over the years, I just kept wanting to learn a little bit more. And then I was fortunate enough to meet Dr. Blackwell, who provides care for the LGBTQ community, and I was able to join on. So this is something that I really enjoy. And at the end of my master's program, I did an evidence-based project about HIV PrEP and communication regarding HIV PrEP, how to navigate that with patients in the primary care setting. So this is my jam. This is what I really like to do. So we'll go through a couple different sections. One of the heaviest ones is about transgender care. I think that's just because that's something that we don't always get to do in nursing school. And so we sometimes have a little bit of an idea of how it works, but not 100%, which can be a little bit difficult to know what to do when you have a patient. So we'll stop, like Nicole said, for questions so that you don't have to kind of bundle them up for too long. All right, so at the beginning, we'll kind of do the basics rundown of just some generic definitions, and then we'll go into gender affirming care, role of the bedside nurse, and then preventive care, communication tips, and resources. So this graphic I really enjoy just because it kind of helps conceptualize both gender identity, expression, and sex assigned at birth. So this is the gender unicorn. So it kind of helps you visualize how these things come to be. So your gender identity is something that it's your innermost concept of yourself. Your gender expression is how you present yourself. And then you can see the little double helix, that is your sex assigned at birth. And as we know, we do that just based on genitals. And then the little hearts are for who you're physically attracted to. And then there's another color for who you're emotionally attracted to, because for some people that can be a little bit different. You may be physically attracted to women, but emotionally attracted to men. So basic definitions. Gender identity, it is, as I said, your innermost concept of self as either male, female, a blend, both, or neither. And I like to think of these two things, gender identity and sexual orientation, as a spectrum. So like a color spectrum. So, you know, we have male, female, and we also have non-binary. So I kind of think of how you have, like, on the color spectrum, the red, the blue, and then they kind of blend together with the purple, but then some of the other colors kind of blend together too. So since it's an innermost concept of yourself, it doesn't have to be in a checkbox. Just unfortunately, a lot of forms, everything else is a checkbox. So this can be kind of a difficult thing for patients sometimes, trying to figure out, well, what box do I check? And a lot of our forms in healthcare only have 2 boxes. And so then you get stuck. Do I check the box that I identify as, or do I check the box based on what gender I was assigned at birth? I know today I had a couple of patients that they checked the box as who they identify as for their gender, but I always tell people, hey, I have to make your chart match your records, which can be kind of difficult for patients until we're able to get some of those things changed. Gender identity is separate from sexual orientation. It is not an assumption. One does not imply the other. And your sexual orientation is your inherent emotional and romantic and sexual attraction to other people. Gender is a social construct. So what we determine is masculine, feminine, is all based on our culture. And some of that, if you just kind of think about the things that we say, how some people, if you know that they're going the gender of their baby based on ultrasound, they're saying, oh, it's a girl. People start buying pink and flowers. But then when we think about it, why? Is it because women are supposed to be delicate and soft? And a lot of these gender roles are really based on culture and where we live, and it kind of shapes some gender roles. And we say it's a social construct just because it varies. There used to be a group of women in South Korea that were the breadwinners in their families, and they did not do the child rearing. And so it's kind of a role reversal from what we have here in the United States, where historically women were always seen as the nurturing type and not the breadwinners, but now it's changed. And like I said, both of these are 2 different spectrums, so they're separate from each other. So now we're going to kind of go through a little bit of definitions. Sometimes these are things that we have heard before, but we aren't always for sure, like, okay, so what's the difference between this definition versus that? So I just kind of wanted to take a minute to go through some of these. So androgynous is someone who identifies or presents as neither distinguishingly masculine or feminine. Asexual is a lack of sexual attraction or desire for other people or specific genders. And then cisgender is someone who identifies and aligns with the sex that they were assigned at birth. So I am considered a cisgender female, so I was assigned female at birth, and that is also how I identify. Gender dysphoria is whenever it's clinically significant distress caused by a person is assigned one gender at birth, but it's not what they identify as. And this previously was called gender identity disorder by the DSM, but now they have realized that by calling it a disorder, it makes it sound like there's something wrong with you, and there's not. Just because you don't identify with the gender that you were assigned at birth doesn't mean there's anything wrong with you. Gender expansive covers a little bit more of a wide, flexible range of gender identities, and this is more referring to a gender system. So not necessarily the individual person. Gender nonconforming is someone who doesn't necessarily identify with the gender that they were assigned, and they don't conform to traditional expectations of their gender. And then genderqueer, non-binary, this is someone who embraces the fluidity of their gender identity, and they don't necessarily see themselves as female or male. You know, they're kind of, a lot of my patients that are non-binary, they'll tell me that, well, it just kind of depends on the scenario. There are some ways that I kind of see how I fit what people think of as masculine, but then there's some things that I feel like I'm more feminine than the average person. So that's a way to kind of describe someone who is a little bit more fluid. And then gender transition. So this is something that we will be talking about today. It's the process of aligning someone's internal gender identity with their outward appearance. And so that can be through clothing, presentation. It can be through hormone therapy. Pansexual is someone who is sexually or romantically attracted to all genders. I know I had a patient once and she told me, I'm a lover of all humans. So that is kind of another way to describe someone who is pansexual. And queer is a way to describe anyone who has a sexual orientation or gender identity that varies from societal norms. So it's kind of saying not heteronormative, essentially. And then transgender is an umbrella term for someone who identifies as a different gender than the gender that they were, or gender identity from what gender they were assigned at birth. So I know it's kind of a mouthful of definitions, and you guys will be able to get these slides afterwards so you can kind of review, because some of them are kind of similar and it kind of takes a second to, I sometimes have to double check and look things up to make sure, like, okay, is that what that means? It's helpful to be able to reference things. So next we're going to dive into the gender affirming care. So first we'll start out with hormone therapy, which is what I do in the office, and then we'll dive into surgical interventions, and then some other interventions that are available for our transgender patients as well. So gender affirming hormone therapy for transgender women, we give a couple of different medications. So we give estradiol, and then we also give medications to help bring the testosterone up. So whenever I meet patients and we're getting ready to start HRT, I tell them we're kind of going to go through puberty again, because we're going to be introducing hormones that your body is not used to, and you're going to be experiencing some changes like you did in puberty. So the way that we do that for transgender women is that we give estradiol, and then we give an androgen blocker to help bring that testosterone down. And we do that either through spironolactone or finasteride. Sometimes we do one or the other or both. It just kind of depends on how we're going throughout the hormone therapy, how much progress we're making. And then for transgender men, we give testosterone. So a little bit easier in that it's just one medication. And then for both of these patients, when it comes to determining doses and how the patient is tolerating the therapy, we look at labs, and we start out looking at their labs about every 3 months. And then the longer that we have them, we start spacing out their visits to about, or their lab draws to every 6 months once we get to the same dose for a little while. That way we can see how it affects their blood counts, and make sure that they're not having problems with liver function, which is really rare, but once we have that stable dose, we kind of know how the patient's going to respond for a while. And we base our dose also on desired effects and patient history. So with estradiol, if we have a transgender woman that smokes, we really encourage them to stop smoking. We try to help them stop smoking, and if it's something that just with time we're not able to achieve, then we sometimes will hold back on going up as high in some of our doses just because of the risk of thrombosis. We just don't want someone to have a clot and to do anything that would cause harm down the road. So we always try to find a happy medium or try something besides oral estrogen. So This is a lovely little graphic. I actually just used this graphic with a patient like an hour ago, so I love this thing. So this is a great way to see how patients have the effects of the hormones over a few months. Because a lot of times whenever they're ready to start the hormones, a lot of patients are very excited, but they have finally come out to their family and their friends, and they've really been thinking about it. They finally have the support that they need and they are ready to go. And then I'm like, so it's going to be like 3 to 6 months before you really start to notice changes, but sometimes you will start to notice changes in about a month. But all patients are usually excited. They're like, that's fine, that's fine. So for estrogen, some of the effects that we will see, the skin will get a little bit softer. We'll have a little bit of a decrease in muscle mass, especially around the shoulders where you can see the pink coloring there. And then we'll have some changes in a decrease in body hair in the little green zones. Body fat will increase around the hips, which can be really affirming of someone's whenever they're going through their transition, where they start to feel like whenever they're dressing, it feels more feminine to be able to have a little bit more shape on your hips. There are a couple different ways that we can give patients estrogen. We can give it in injections, patches, or pills. Almost all the patients that I see and that I saw throughout my master's program do the pills, because with the patch and the doses that we need to give, you end up having to wear a couple of patches, and then you have to try to remember, okay, which one's my new patch, which one's my old patch, and keep track of them, which can be kind of difficult. And it's a little bit more expensive. So we do the pill. So it's kind of like giving half of the traditional combined oral contraceptive that we give for patients. So it's just the estrogen. Sometimes we'll give progesterone, but it's pretty rare. And a lot of times there's anecdotal evidence that it helps with feminization, but not very often. So I usually only do it if a patient has been on the estrogen for a little while and feel like they're just not making a whole lot of progress. And a lot of times patients will come asking for certain things because they've met other people and they're like, well, my friend takes this and this really works for them. And so then you kind of have to talk through, like, everyone's a little different. We can try it. Doesn't mean you'll get the same effect, and kind of work our way through that. So for testosterone, the only two administration options are injection and gels. And with testosterone, you'll see some of the changes. It's kind of some of the opposite effects. So patients will start to, first thing that they'll usually notice is that they'll start to get oily skin. Then a couple of months, menses will cease. They'll start to see their clitoris enlarge in the first 1 to 3 months. Scalp hair will change. They'll get a little bit of male pattern baldness, which can happen. So it kind of depends on your family history. If a lot of the cisgender men in your family are bald, you may end up bald too. It just kind of depends. And then we'll also see a little bit of change in the pitch of voice. And then we also see a little bit of increase in muscle mass in the arms, which can be very affirming for patients. Most of the side effects related to these medications for estrogen, it's usually migraines, mood swings, hot flashes are potential side effects, but it doesn't happen too often. And it kind of depends on their history. Like if they have had problems with migraines in the past, then we may have a little bit of problems with having migraines more frequently after starting estradiol. But not too many people have problems with side effects too often. With the testosterone, acne is a side effect that some people get with the testosterone therapy. So what questions does everyone have about hormone therapy?
You all can just throw them in the chat and I'm happy to kind of read them out loud for you. Or you can, even if you want to be anonymous, feel free to DM them to me directly. That's totally fine. I have a question while we're waiting for some questions.
Okay, yeah.
For patients who just don't tolerate the hormone therapy for whatever reason, is surgical intervention the next step, or like what is the next step from there?
Yeah. So some patients, if they're not tolerating hormone therapy, we can do surgical interventions. So say for a transgender female, they're really having a hard time with their potassium levels with the spironolactone. we can do an orchiectomy, which would help reduce having to fight the testosterone so much. And it can also be affirming just to get rid of the testicles. That can be an option. Or if patients are just having a hard time with the hormones, then sometimes we just can't do any hormones. And so we look at like cosmetic things to try to help, cosmetic interventions to help with the feminization process. Hormone therapy is sometimes covered by insurance, but some of the other therapies are not. So we always try to do the hormone therapy if the patient wants it, and not all do. Some patients don't care to do the hormones. They're like, that's fine. Like I'm happy with the way I am. Like I feel like I can present the way I want to. I feel masculine enough. Like I don't feel like I need to do more, and that's totally fine.
Okay, awesome. Thank you for answering that. We have a couple questions. Curious about any common contraindications with other meds.
Yeah. So for most patients, they tolerate it pretty well. If someone has problems with their liver, the estrogen can be a little bit problematic, the oral estrogen. Luckily, since we have a couple of different ways to deliver these hormones, we can sometimes work around any kind of interactions. But since the oral estrogen does go through the liver, it can cause a slight bump in some of the liver enzymes. It's pretty rare, but if someone has an underlying condition, then we could consider doing a different mode. But for the most part, everyone tolerates it well, because one thing to think about is that as a human, we all have hormones in us, whether it's estrogen or testosterone. And so when we do this hormone therapy, we're switching the hormones that are in their body, but it's still in a human, which helps so that the body can adjust. Because we all start out initially androgynous, until we get, I think it's like 12 weeks, I can't remember. But at one point, that's whenever finally our genes start kicking in and changing the genitals, and then eventually create the ovaries, which secrete estrogen, and then the testicles, which help with testosterone production. So since you're going human to human, it usually works pretty well.
Okay, awesome. We have a few more questions. We can try to get through these pretty quickly.
Okay.
Are there any age restrictions for hormone therapy? As a former peds nurse, I do wonder about that.
Yeah, that's a great question. So here where I practice, since we do pretty much adults, we will start patients in our office. 16 is the youngest. My youngest patient is 17. Dr. Blackwell, who I work with, I think he has one 16-year-old. But that's the youngest that he will do. In terms of outcomes, starting a little bit younger, you won't have to kind of like reverse the puberty that someone has already went through. I know where I live here in Indianapolis, there are more pediatric hospital systems that are starting to develop gender clinics. So I know Riley here in Indy has a gender clinic, and they sometimes will give hormone blockers for kids who are kind of in that prepubescent age. So like right before being a teenager, when they may start their menses, kind of around that age, they'll sometimes give them hormone blockers to buy time, to give the kids a little bit more counseling, talking to them, and just kind of help them talk about how they identify, and not in like a conversion therapy kind of way, more in trying to help understand how the kid kind of got to that place. To be able to do it by yourself, because HRT, transgender care, is not an emancipated condition. You have to be 18 to sign for yourself. Otherwise, you need parental consent.
Okay, awesome. So I think that answers another question, if do minors have to get parent permission?
Yes.
Yeah, okay, I figured. Okay, this is a longer one. So what would be the response to a patient who requests a similar hormone therapy as their many friends, but which would not necessarily be beneficial to them? Would it be ethically sound to prescribe them at their persistence, even though you understand the patient might not see detrimental effects, but it would not benefit them more than another hormone type or combination or treatment?
Yes. So I have had patients say like, well, my friend injects this much. And sometimes they go to a different provider, or sometimes patients will ask like, well, if I go to an endocrinologist, will they give me more? And I kind of talk them through why we do the doses that we do. And usually once you explain why and what you're watching for, then they're on board. So for testosterone, I always tell patients more is not more, because if you inject more than what has been prescribed and you get your testosterone levels so high, your body will actually, a female body, female assigned at birth, will convert that testosterone back into estradiol, which makes you take a step back. And I feel like as soon as I tell someone that, they're like, don't worry, I will follow the rules. Like, people are on board with that. And then for patients with estrogen, sometimes if they feel like they're not getting enough feminizing effects, then sometimes we will consider adding like the finasteride. And I always explain to them that these are potassium sparing diuretics. And so we need to stay hydrated. We need to stay on top of things. So I always try to, if someone is kind of pushing to get the same dose as someone else, I always explain why. And I tell them their lab results whenever I get them. And I tell them what lab numbers we're shooting for, so that they can see like, oh, okay, I'm actually in range. Or sometimes patients, they'll be like, oh, I'm actually at the top of the range. And so they'll usually, patients are okay with that.
Okay, great. That's super helpful to know. Are there any specific precautions in certain disorders or diseases?
Mainly the biggest one is with clotting, or thinking about family history of cancers, like breast cancer mainly. So say you are a transgender woman and your family has the BRCA gene. By giving estrogen, we may see an increase in the risk of breast cancer. The tricky part is there is not a ton of research. Research is like really taking off in the past 5 years, but we don't have a ton of long-term studies. And a lot of, in the past, because we didn't provide a lot of formal medical care, some patients had other ways of getting their hormones. And so then, we don't have a way to see like people who have been on hormones for 50 years. We don't have that many of those patients to be able to truly know. So it can be a little bit tricky, but 100% contraindications would be someone who, say, has had a thrombotic stroke. And I actually had a patient recently who had a blood clot. They had a PE and they were young and wanting to start estrogen. And I told them we need to get cardio clearance. And so I'll reach out to their other providers and ask their perspectives on starting something that could increase their risk of clots, and work together so that if maybe the estrogen will affect their need for anticoagulants or anything, we're both aware and on the same page.
Okay, cool. This is the last question before we move on.
Okay.
It's an important question.
Yeah.
I work at the hospital. How important is it to continue therapy throughout hospitalizations? Sometimes hormone therapy can be out on hold until acute illness is cleared.
Yes. That thought always crossed my mind too whenever I did surgery recovery, because, I would sometimes pass them off and then I would wonder what happens on the floor. So it is okay in terms of physiology if someone is off of their hormones, say for a short hospital stay, but it can be distressing for patients because a lot of times, a lot of patients have suppressed some of these thoughts and feelings for a long time, and then finally are proud of who they are and have come out to their friends and family and are feeling good, and finally feel like when they look in the mirror, that's me. And then whenever they have those hormones that they can't get for a few days or weeks, it can be stressful. So I think from my perspective, if the patient is stable, they're not in the ICU, they're not about to go back to surgery, I don't see why they couldn't keep their hormones going, but that is all based on a hospitalist and whoever is providing the care inpatient. But I think if the risk of clots are like no immediate risk or anything, it would be great in terms of just providing affirming care and respecting the patient for who they are to keep those hormones going, if at all possible. But I can't speak to how often that is done.
All right, awesome. Well, thank you for answering those questions. We can move on to the next section.
All right. So next section, we'll talk a little bit about surgical interventions. So there's a variety of options that we can do, and some of these are covered, some of these are not covered by insurance. So that can depend on where you work. And I know I've seen patients before who take jobs just because they may not love their job, but they keep it because they actually have transgender care benefits there. And I don't blame them. And surgical interventions are also something that people sometimes go to other countries for, because if you don't have any insurance coverage here, it's cheaper. I think Thailand is a pretty common place to go for transgender care. And then Mexico is fairly common as well. But it seems like Thailand's a little bit more common of what I've seen. So first option is masculinization chest surgery, or what is commonly called top surgery. So that would be for a transgender male. They can go in and they can remove a lot of the mammary ducts. And the beautiful thing about this, from some of the studies that we do have so far, is that it can reduce your risk of breast cancer, which is kind of nice. So at least have at least a little bit of something to reduce the risk. So both affirming care and, you reduced your risk of something else. With the top surgery, we may still need to screen for breast cancer down the road, depending on family history, but that just kind of depends on the patient's history. If they have a family member that had a really aggressive breast cancer in their 30s or 40s, we may watch them a little bit closer, and after that breast tissue is removed, we can always use MRI or an ultrasound to check. Breast augmentation is an option for transgender women, also referred to as mammoplasty, and they can get implants to try to help. They can either do it via liposuction or like the different implants that can go in. And women who have some of the implants, they can still get their mammograms down the road. Ovarectomy. So for transgender men, we can remove the ovaries. And one way this sometimes can get covered is if someone has had a lot of problems, any problems with like ovarian cysts or anything else along the way, can kind of help. Unfortunately, with trans care, sometimes you have to kind of, you almost feel like you have to play the game to try to get insurance coverage for the patients, in a sense that, you have to think of what interventions would have dual purpose, both with gender affirming care and help with another underlying medical condition. Orchiectomy, kind of like what I mentioned earlier, by removing the testicles, then we have lower rates of testosterone, so it can decrease the needs for spironolactone and finasteride. Vaginoplasty, so if you like to watch the little like animations of how surgeries occur, this is a really interesting one. So vaginoplasty, I've been able to see, there's a plastic surgeon that used to be here in Indianapolis, Dr. Gallagher. I believe she now practices in Miami. She does this procedure. There aren't a ton of providers here in the United States who do. I know there's some in Chicago, Pittsburgh, but it's really neat. So with the vaginoplasty, they're able to take a penis and they separate the urethra, and then they invert. They use the skin from the penis to invert and make what's called a neovagina, and then they're able to place the urethra back to where you would expect it to be for a cisgender female, and it is fully functional. So still get all the benefits of sensation and for sexual pleasure. They do have to do some dilators since it is a different kind of tissue than what you would find in a cisgender vagina. They do have to use some dilators just to keep it from closing. But the longer that they have had the vaginoplasty, the less frequently they have to use the dilators. And then the phalloplasty, that is a way that they can take skin from sometimes a forearm or a thigh, and they're able to use the skin to create a penis. And then they also will use skin to make a scrotum, and then they can do testicular implants that are just they're cosmetic. They're not necessarily like secreting testosterone. That would be really convenient, but it doesn't exist. So that is another option. These are sometimes surgeries that people save a long time for. I know right at the beginning of COVID, I saw a few patients in the office, and some had saved for such a long time for their surgeries, and then transgender surgeries in most places were considered elective, and everything got put on hold. And I know, because some of these surgeries are like $30,000. So to save up $30,000 is not easy, and the patients are ready to go, and then they couldn't do it. Another option that patients can do is a reduction thyrochondroplasty. Sorry, I'm not super slick at that. So what they do is they go in and they shave down the Adam's apple. And it really does make a difference. Around Christmas time, I remember I recovered a patient that had this done, and she was so excited to show me her before and after pictures, because she still had a little bit of swelling because she had her procedure done that day. And by doing that, it gives the neck a little bit more of a feminine look, and it was really cute. She's like holding her phone up. She's like, see? Like, yeah, it does look different. And then another option is voice surgery. So some ENTs are trained on this, and they can actually stitch the vocal cords in a slightly different pattern. And if I'm remembering correctly, when the vocal cords are a little bit longer, more linear in their shape, they will vibrate at a higher pitch. And so that is an option to help patients who have been through vocal training and start having a hard time getting their voice to hit some of those higher pitches, so that they can sound more feminine and feel like it usually can be very affirming, because then with phone calls, that can be a stressful thing for some transgender patients, where, you know, when you walk in somewhere, if someone looks at you, they say sir, and they recognize how you identify. But then whenever you make a call, someone says ma'am, and then you're like, dang, like, just when I thought I was doing good. It can be tough for patients. It's definitely taught me a lot to consider, like, sir and ma'am are meant to be polite, but don't always have to do them. There are other ways to still be polite without making assumptions. I'm getting a little bit better at that, trying to get a little slicker. So like I mentioned before, some other interventions are vocal training. At least as of a year ago, there's literally one book on how to do the vocal training for speech therapists. And there are a couple here in Indianapolis, and they're scattered throughout the United States, but speech therapists who can teach patients, and it's really cool to listen to the recordings, and they will teach patients how to vibrate their vocal cords a little bit differently, so that the pitch of their voice can be a little bit different. And they always do a recording where they have them read the same poem at the beginning of their therapy and at the end. And it's usually pretty intensive. It's a couple of months, and it's once or twice a week. And they're like hour-long appointments, which, like, to just have someone keep talking to you and you keep saying things back for an hour a couple times a week, I'm sure that would get a little exhausting, where you're like, I'm trying. But it can be really helpful. It's really neat to hear those clips to learn from it. Laser hair removal can be helpful for some patients. I know sometimes for transgender women, the stubble that sometimes doesn't go away with the finasteride and spironolactone, that can be a way to try to help a little bit, because I know sometimes patients will try to use makeup to help cover it up a little bit, but that would be hard to try to keep covering it up. Genital tucking is another thing that patients do, so that if they wear clothing that is more feminine, so that they don't have anything that makes them feel like I look more masculine, and then breast binding is pretty common too. With both of these things, whether you work in inpatient or outpatient setting, some patients in the inpatient setting may want to keep their breast binder on as much as possible. As long as they have it off for 8 hours, that is good. And as long as they don't have any breakdown. And I always ask my patients, do you check to make sure you don't have any breakdown? It's not very common, but sometimes patients will, especially if you can't, afford to have the top surgery to help reduce your the size of breast size, they'll bind it really tight because your breast size is dependent on genetics. So you can't really change that. And some patients have had problems with skin breakdown. And it almost makes you wish you could give away Methylex for patients and just like pat them up and then they can do the binding. But we don't do that very often. But I always remind them to do skin checks. So that is something that I could see where as long as you can keep their monitor on and everything, you could keep that going in the inpatient setting. And that's definitely a way to help them so that they can still present in a masculine way and not have a lot of providers like walking into the room and saying like, hi, ma'am, and, kind of makes them feel like, oh, I took a step backwards, which can be difficult. All right, so adjunctive surgical interventions. What questions do we have?
Give people a few minutes to type.
Okay, oh yes, no rush.
That was super helpful. It really makes you think, how you address patients and making assumptions, and just have to make sure you're checking yourself constantly.
Yeah. And a lot of times before I go into a room, I always pause one more time just to double check that I know the name that they usually go by and their gender so that I don't mess it up. So far, so good. I know it'll probably happen. And you just apologize. You try not to make a big deal of it and try to keep rolling. But it's definitely worth the effort. When I ask patients their pronouns, sometimes patients get super excited. Like, thank you for asking. I would love to tell you about them.
That's awesome. Looks like we have a question. Do people need to hold off on hormone therapy prior to surgery?
So that would be dependent on the surgeon. And that also would be dependent on some of their clotting factors. So if the surgeon is willing to check their PTP, their INR, just to make sure they're doing okay, and looking at their H&H. So with testosterone, the reason why there's a slight increase in the risk of clotting, it's because the red blood cell will get a little bit larger. And so once we get to a hematocrit of about 54, that's when we sometimes will start slowing down. But a lot of times they could keep it rolling as long as they're within normal range for their gender that they're getting hormones for. So after about 6 months, labs, you go a little bit more based on what gender they identify as and the hormones they're receiving them for, because H&H, hemoglobin, and hematocrit is slightly different for males and females. So when someone is on hormones for about 6 months, then they can, you look at the labs a little bit differently. So it'd be just like a cisgender female before surgery. We don't give anything to block their estrogen leading up to surgery because it's always in there.
Okay, awesome. We have another question. I'm in the ICU setting. Anatomically and post-surgery, is it safe to place a Foley catheter?
Like after, I'm guessing this is after a vaginoplasty or phalloplasty. Does that sound right?
I'm the same. Kelly, if you want to let us know. Yes.
Okay, they come out of surgery with a catheter and they keep it for a couple of weeks. Sometimes they're doing it a little bit less. It may have changed since the last time I saw a talk, but they come out with it on. So luckily, you will not have to place that first catheter, because I would imagine that would be a little nerve-wracking with all the swollen tissue. They place the Foley at the beginning of the procedure, and it also helps a little bit whenever they're separating tissue. The catheter is in the urethra, so it kind of makes it where it's a little bit easier to separate all the tissue. So they will already have that. Sometimes they'll even go home with it. So they should already have one, but down the road, if you have someone a couple of years later, because patients are going to live for a while, at least that's the goal. So you may have to place one, and so it will look a little bit different. The skin will not be quite as plump. just because the tissue is a little bit different for making like the labia minora, majora, since it's a different kind of tissue. So your landmarks may be a little bit different, but it is, they try to construct everything to be as anatomically similar to a cisgender person.
Okay. And this is kind of goes back into it. So with post-healing, when it's swollen, if they come in with like an unrelated hospitalization, would it be okay to do a Foley then, or?
As long as they are done with their post-op phase and they have been cleared, you can still use it. We aren't using, I shouldn't say we, I don't do the surgeries. They aren't using any new tissue to create a new urethra. So it's still the same tube that is built to handle urine. It's just been moved. So it would be okay to still place a Foley afterwards.
Okay, perfect. Thank you for all that.
Yeah.
We need to head on to the next section.
All right. Next section, role of the bedside nurse. So slightly elevated risk for thrombosis. So the reason why I mentioned this, because I know like earlier I'm like, oh, well, the clots don't happen too often, so I know it's kind of slightly conflicting things, is just to keep in mind if you have a patient come in and if they are trans and say they're starting to have a transgender female having a lot of pain and cramping in one of their calves or swelling, and you look at their med list, consider DVT. And then similar with testosterone, very rare side effects that can, or adverse event that can happen with testosterone is if you're to inject the oil into the blood vessel, then it can travel to the lungs and cause an oil embolism. But for a lot of patients with the oil embolism, they will cough for a little bit and then it works its way out. Then they're okay. But that could be a potential cause. So if you had someone coming in with difficulty breathing and you knew that they injected their testosterone that day because they only inject testosterone once a week, or even as they get down the road, they do it bi-weekly, every other week, that is something that you could keep in mind. And like I mentioned before, the elevated risk of clotting with testosterone is because the red blood cell itself gets larger. In estrogen, it's a different pathway and more so related to the pill form of estrogen. And that is because whenever you take oral estrogen, it affects your liver and affects some of the clotting factors that are in your liver. So if a patient is on patches for their estrogen, they will not have the same risk of clotting, and that's just because we're not getting that first pass effect and the change in the clotting factors with the liver. So the other part of the bedside nurse, which is something that I feel like a lot of nurses are so good at, is being the patient advocate and really sticking up for your patient. And I know with people presenting, everyone presenting or putting in their questions ahead of time, this was kind of something, it was a common theme, and it was really heartwarming too. I was talking to Dr. Blackwell, the provider that I work with this morning, and I think his heart was kind of warmed as well to think about how many people really care and just genuinely want to help patients and help them be more comfortable and ensure that they feel cared for and we're respectful. So one of the first ways that we can do that to be a patient advocate is to use their pronouns. Use the pronouns that they use to describe themselves. So one of the tricky things with pronouns is sometimes figuring out what someone's pronouns are, because you don't want to assume, and it's not always comfortable to ask, but the more you do it, you get a little bit more comfortable with time, it gets a little easier. So listen to the pronouns that the patient uses to describe themselves. Listen to people who are close to them. I know in the inpatient setting, you sometimes get this lovely dynamic of family coming out of the woodwork, which maybe not so much right now with visitor restrictions, but sometimes, you'll have the family or friends that are very close to the patient that are actively engaged in their lives, and the people who have not shown up in a couple of years, and all of a sudden, voila, they're there. listen to the pronouns of the people that the patient seems comfortable with, not the pronouns of long lost dad, long lost grandma. You know, they may not use the pronouns that the patient goes by, and so you don't want to echo the wrong ones. Another option is to lead. And so one way that I introduce myself to my new patients is I come in the room and I say, hi, my name is Sondra, she, her, hers. I'm a family nurse practitioner. I'll be seeing you today, and kind of go into my little spiel. And you could do that as well whenever you go in the room. And we usually do, like, you know, the little quick hello, like, hey, I'm going to be your nurse. I'm going to go check on some things. I'll be back. You could certainly do that. You can pop your head in, say, hi, I'm Sondra, she, her, hers. I'm going to be your nurse until 7. I'm just going to go get a report on my other patients, and I'll be right back. And if you just kind of work it in, patients will kind of think about it. And for some patients, they'll kind of pause and wonder, like, why is she just saying she, her after her name? But for some patients, that is going to make them feel like, okay, all right, they're thinking about it. They are cognizant that not everyone is the same. And then you can always just ask. And I sometimes just ask my patients, I say, what pronouns do you use for yourself? Or what pronouns do you use? And patients will just tell me, and then I use those pronouns for the rest of the visit, and every time I see them thereafter. And that can be a helpful thing on report sheets whenever you're passing off to, once if someone asks and we know the patient's pronoun, make sure that is passed off, because a lot of charting systems do not have a place to mark transgender male, transgender female, non-binary. So you don't know what to use, so you kind of have to rely on each other, which is difficult. I think Epic, I have a friend that works for Epic, I think they were trying to work on that. I don't know if it's fully in action, but EMRs are starting to try to catch up and find ways to make that available for providers so that you know how that works. And then another option is to be neutral. So use the patient's name. Try not to do like the, all right, hun, like trying to buy time to figure out what their pronouns are, but to use their name so that they know that you are speaking to them, and that you're acknowledging them. And then as a bedside nurse, kind of like I mentioned with the family who just pop up, remember that you have your biological and your chosen family. Try to avoid assumptions. Say spouse instead of husband or wife. Whenever you're asking if they want you to call anyone, if they're concerned about anyone. And then for peds, say parent instead of mom or dad, because sometimes kids have 2 moms, 2 dads. And you don't want to make assumptions, and you want all parents to feel included, to not feel like they don't exist. And then send up good red flags. So I have a little pin that has, it's like the little medical symbol with a rainbow flag on it. Sometimes little things like that, patients will notice, and I've had patients point them out. I also have like some transgender flag earrings, and patients notice it, and they know that you're cognizant of these things, and that you want to make them feel loved and welcome and cared for. All right, questions about advocacy.
We actually are running a little behind.
I saw that.
So we'll skip this question section, and just to make sure they get the material, and then we'll kind of see how much time we have left.
Yeah, that sounds great. So one of the last parts is HIV PrEP therapy. So people who are candidates for HIV PrEP is someone who is currently HIV negative, or someone who is living with a partner that is HIV positive and has a detectable viral load. Anyone who has been diagnosed with an STI in the past 6 months, it's worth considering. Anyone who reports IV drug use or needle sharing. Anyone with condomless anal sex, either insertive or receptive, and especially if they've had more than one partner in the past few months. And then also anyone who's requesting PrEP. So if a patient is interested in PrEP, then it's definitely worth considering. Currently, gay and bisexual men account for about 70% of new HIV diagnosis. So this is something to spread far and wide to know that it is an option. So HIV PrEP is HIV pre-exposure prophylaxis. It's a once daily pill that can reduce the risk of getting HIV by about 99%. And this is just an easy way to kind of see why we see such different rates in different populations. And it's just because of the anatomy. The tissue walls are a little bit different, whether you're having anal or vaginal intercourse, and whether you're having receptive or insertive intercourse. And so receptive anal intercourse has the highest risk of acquiring HIV. So HIV PrEP, there are 2 medications available, Truvada and Descovy. It's a once daily medication, reduces the risk by 99%, like I said. We follow people closely with labs, just because they can have a slightly decrease, a slight drop in their kidney function. And we want to ensure that someone is still negative, because some of the ingredients in these medications are also used to treat HIV. So we want to make sure that they have the right dose to prevent HIV, but if they convert and become positive, then we need to give higher doses, different medications. Any questions about PrEP?
I think we'll move on to the next section.
Just move. Okay.
Yes.
Oh no, you're good. You're good. I get chatty. So
No,
mental health.
So much great information. There's so much to cover.
There is. So mental health, I kind of wanted to briefly touch on this one, just because it is so prevalent. And the one that really stands out to me is in a transgender adult's lifetime, about 40% attempt suicide. And this is all just very related to discrimination and to minority stress. And it's really unfortunate, and is also a very good reminder of why it's so important to treat these patients kindly and to do what we can to be supportive. And I feel like as nurses, usually in our education, it's really emphasized to the patient is what matters most. It doesn't matter your beliefs, because I know there are some people that have different beliefs, but when you're providing care, that doesn't matter so much. Keeping the patient safe and giving them what they need is the major priority. And one thing, we have the suicide attempts. We don't really know exactly how many people die from suicide, because with death certificates and the like, it's binary. So you have to check either a box, male or female. There is no box on the death certificates to note if someone is transgender, non-binary, or anything of the like. So we don't really know exactly what the rates are for specific populations. And I'm just going to give some resources here, and then we'll open it up for questions. So resources for practice. WPATH is the World Professional Association of Transgender Health. They have guidelines for treatment. Fenway Institute, this would probably be really, out of all these resources, one of the best ones, because they have so many free continuing education opportunities. They have articles and recorded lectures and guides. They have things for like how to make patients more comfortable, how to make like waiting rooms a little bit more friendly. And then UCSF, they have fabulous transgender guidelines. I have their guidelines printed and right next to my desk all the time. I like to have it for a nice reference. And then a great way to find LGBTQ friendly providers, which unfortunately is kind of a thing to be able to, that some patients have to look to see who will be kind to them. OutCare is a website that patients can use. And then Included Health is also an option. Included Health partners with health insurance companies, with employers, to help employees find LGBTQ friendly providers, whereas OutCare is free, open to anyone. And then resources for patients. For LGBTQ youth, the Trevor Project, they have a crisis hotline, the It Gets Better Project, to provide patients with a source of kind of somewhere to look for empowerment and to try to help with resonating and getting that confidence and that pride and being happy with who you are and knowing that there are other people like you and you're all fabulous and everyone's has good in some way. And then also families, because a lot of families have a hard time adjusting, because it is such a big change, whenever you're trying to transition about hormones, or I'm sorry, with pronouns. Sometimes families are a little bit hesitant to adapt with the patient, but there are a lot of beautiful families who are on board, and they are supportive, and they just want to help their kids in any way they can. Okay, questions, sorry.
That was awesome. Thank you. And I have actually used a couple of those websites the other day, and they were amazing.
Good.
Definitely advocate for those. So there was one question I want to cover. Are there ways we can advocate for changes in electronic charting systems to allow for people's pronouns?
Yes. So I actually attempted this too. I was hoping I could do it before I left the bedside. It just didn't work. I know a lot of the big charting systems come around, and, they sometimes have like a liaison that comes to you, like, oh, you have any questions about the changes? Start speaking up and saying, hey, where do we put the gender for a patient that's non-binary? Hey, where do I mark for a patient that's transgender, male or female? And the more that we all start asking for it, the more that leaders will start noticing that, hey, we need to do this. And a lot of, if you are with a larger organization, you can look up the email address of your CNO. And so you can certainly shoot them an email and let them know, like, we should do something. And more healthcare systems are trying to host conferences or different things to try to make their EMRs a little bit more friendly. So I think just speaking up anytime someone pops by and says, do you need help with anything? Like, technically, no, I don't need any help, but I have a comment. It's definitely worth speaking up.
Okay, awesome. Well, if anyone else has any, we have time for maybe one question since we're already over. Feel free to ask questions or share your feedback for the event. But honestly, Sondra, that was amazing. I learned so much, and I feel like I can take that, use it in my daily life, and be a better person, better nurse for it. So thank you.
Yeah. Thanks for inviting me.
Yeah, of course.
Looks like everyone is saying they learned so much. Lots of claps. So great. Thank you. Really, again, I'm so impressed. Not a nurse, and I'm just beyond impressed with the amount of information that you shared tonight. So thank you for everything. And to all of you who participated and joined us, we appreciate you as well. As I mentioned before, you're going to get a survey. Please share your thoughts and feedback with us so we can continue to put together events and experiences like this for future nurse support. So no other questions with that. Just, again, thank you. Have a great night and take care of each other. Bye, y'all.
Bye, guys. Y'all take care. We will send out the recording of this event, so you will receive it.
Thanks, guys.
No worries.
Bye, y'all.
Right. Bye, guys.